I'd like to welcome Dr. Beth Morgan for her talk on status epilepticus in neonates and children. Dr. Morgan is a child neurologist with the Norton Children's Neuroscience Institute and is an assistant professor at the U of L School of Medicine. She completed a fellowship in neuroimmunology and multiple sclerosis at the Ohio State University Medical Center. And she has several interests in addition to neuroimmunology, including pediatric emergency and neurocritical care, applying evidence-based medicine to clinical practice, student and resident education, neurologic manifestations of systemic autoimmune disease, autoimmune encephalitis, and then she's also been instrumental in increasing our presence in our neonatal ICU at Norton Children's Hospital as a neurology group. So thank you, Dr. Morgan.
Good afternoon. Can everyone hear me okay? Okay, good. So let me share my screen. So it's a pleasure to be with you here this afternoon. And
Dr. Morgan, we're hearing you fine, but we're not seeing your slides.
Let me see. There we go.
All right, got it.
Got it?
Yes.
Okay. So talk a little bit about status epilepticus, not only in older children, but neonates. So I do not have any financial disclosures. And today I hope that we can define status epilepticus and recognize that it's very important to promptly identify kids with seizures and also provide them with prompt treatment. Also to go through a stepwise logical approach for treatment of status epilepticus. And then also just briefly touch on situations where continuous EEG is helpful. So with regard to status epilepticus, we basically have two different varieties, the most common being convulsive status epilepticus. Non-convulsive status epilepticus, I think, creates a lot of anxiety in most people as far as, obviously we can't identify it without EEG. In convulsive status epilepticus, we basically divide treatment into neonates. Neonatal treatment is very different from treatment of older children beyond the neonatal period. So when I see a patient in the hospital with a first-time seizure or status epilepticus, the worry is, the seizure is going to continue and last a long time and cause permanent damage. So most seizures actually stop on their own without treatment about 92% of the time. The average of a new onset seizure as far as timing is about 3 minutes in most. However, if you look at the graph, are you able to see my cursor? So once you get to about 7 minutes, then the seizure, the duration and the cessation of seizure drops way down. So I think the takeaway from this figure is the longer the seizure goes, the less likely it is to stop, which is why early treatment is important. So I think Dr. Sa alluded to some of these things with regard to just the basics of seizures and epilepsy earlier today. So what is status epilepticus? It's a failure of the mechanisms responsible for seizure termination or there are new mechanisms that lead to abnormally prolonged seizures. Status epilepticus does potentially have long-term consequences, including neuronal death, neuronal injury, and permanent alteration of neural networks. So the traditional definition of convulsive status epilepticus is 30 minutes or more. However, in animal studies, there is good evidence that there are detrimental effects prior to that 30-minute time mark. Therefore, the Neurocritical Care Society suggested a new definition of status epilepticus in 2012, which is greater than or equal to 5 minutes of continuous seizure or 2 or more discrete seizures with incomplete recovery in between. So how common is status epilepticus and what is the burden to our system with status epilepticus? So it is not terribly uncommon per 100,000, the incidence in most studies. So we see a good bit of it in the hospital. As you can see here, it does carry some risk of mortality, so it's a very serious situation and life-threatening. It is costly to the system for admission for status epilepticus, with the median cost being around $9,000. And that was data from 2019, so I'm sure it's more than that now. So as I said, we see status epilepticus and obviously see seizures quite often in the hospital, and it is the most common neurodiagnosis that requires hospital admission. So I showed you earlier the types of status epilepticus. We have motor symptoms, including convulsive status epilepticus. There's also myoclonic, focal motor, tonic, and hyperkinetic. And then also a non-convulsive status epilepticus. So when we're talking about treatment, when I go through treatment in just a minute, I'm going to be referring mostly to convulsive status epilepticus. It is the most common type of status epilepticus, and prominent motor symptoms, about 93%. So basically the majority. And there is a kind of median common age, about 2.9 years. And as far as non-convulsive status epilepticus, it's not all that common, and we don't really know how common it is in children. However, in a study of adults, there was about 14% of those adults with initial control of convulsive status epilepticus with persistent impairment of consciousness who had non-convulsive status epilepticus. So it's something we have to keep in mind and we have to look for. I think the caveat of this is that consciousness remains impaired. So this is one of the things, if a patient is recovering, then non-convulsive status epilepticus is probably less likely. So as far as causes for, or kind of categories for status epilepticus, prolonged febrile seizure, there can be febrile status epilepticus, and if we are talking more than 15 minutes, we actually put that in the category of complex febrile seizure, which I'll not talk about today. So for febrile seizures, usually 5 months to 5 years is the age range. Beyond 5 years, if you have fever and you have a seizure, that is not your free pass and not classified as a febrile seizure. There has to be a temp above 100.4 and no signs of CNS infection. So acute symptomatic seizures, so basically a provoked seizure, previously neurologically normal, and the status epilepticus or seizure occurs within 1 week of infection, some metabolic abnormality, intoxication or head injury, hypoxic injury, or stroke. So remote symptomatic with status epilepticus in seizures or initial seizures, we sometimes know kids who have maybe a neonatal encephalopathy, so some pre-existing CNS abnormality, but there's no reason, no acute change or insult that would explain why they suddenly have seizures or status epilepticus. So there's also the category of remote symptomatic. So even kids who have a previous CNS abnormality, there's some acute insult that tips them over the edge to have status epilepticus. And obviously epilepsy related, and a patient we already have diagnosed with epilepsy is one of those causes. So when we're talking about status epilepticus, most of the patients of the first episodes of status epilepticus fall into either the febrile status epilepticus or acute symptomatic convulsive status epilepticus. So there's also a good proportion of remote and acute on remote, and that really gets the bulk of all your etiologies. So regarding assessment of status epilepticus, there is an American Academy of Neurology practice parameter and some recommendations. The level of evidence is not outstanding for most of the studies, so it's really an area that needs more investigation and actually more options. So in children we know have epilepsy and they are on anti-epileptic medication, drug levels are helpful, especially if non-adherence is suspected. And then toxicology screens. I think this is something we want to think the best of people, and this does happen a fair number of times, that we have an acute ingestion and our urine drugs of abuse screen is negative. However, the timeline of recovery fits with an ingestion. So if no other cause is apparent, the child's not febrile, doesn't appear to have any infection, then it's a good thing to think of in an expanded toxicology screen, or if we know what medications are in the home, sending specific tox screens for those. So level C evidence, EEG in new-onset status epilepticus. EEG is helpful to gauge the risk of future epilepsy, and also may guide medication choices, but not in the initial treatment of status epilepticus. So EEG, I find that it's not as useful after a child's been treated and the convulsive status epilepticus has resolved and the child does not have persistent impairment of consciousness, because there's usually just post-ictal slowing. So I tend to, especially with complex febrile seizures, I tend to hold off on the EEG until the child's well, and then get the EEG when the child's well, if I have that scheduling capability. Also, we have to think about, always consider non-epileptic events or pseudostatus. And EEG is really the gold standard for diagnosing paroxysmal non-epileptic spells. So that is one reason why you would do an EEG. So as far as the practice parameter, there's not sufficient data to say that you need to do these things, but they should be considered on a patient-to-patient basis. So blood cultures, lumbar puncture, the only caveat with lumbar puncture is they do recommend an LP in infants, or consider an LP less than 6 months of age, or persistent alteration in mental status or meningeal signs. And that's actually from the practice parameter for the first non-febrile seizure. So I think we also need to Think about this in initial onset of status epilepticus. Routine neuroimaging is not recommended, but as I said, on an individual basis, we may choose to do that. So, treatment of status epilepticus. One thing I want to point out is clinical judgment always should take precedent over any kind of treatment protocol. Obviously, to study our how well what we're doing is working, we have to have a standardized treatment so we can look back and say, hey, did we follow our own treatment guidelines? How do those work? How do we revise those for the future and improve things? So as far as inclusion criteria, obviously the patient had a seizure. There's a history of seizures, risk of recurrence. Non-epileptic events is an exclusion. And then one thing that is important, does the patient already have a customized, individualized seizure action plan? Some patients will have that, and those seizure action plans are actually formed from the, sometimes from the Epilepsy Foundation website. And I will touch on that. The Epilepsy Foundation website for seizure action plans for schools and daycares is very helpful, and you can get PDF copies of that. So initial treatment, obviously ABCs. Consider finger stick glucose, get IV access, and then the first line administration within 5 minutes is usually benzodiazepines. So if there is a high suspicion for non-epileptic events, then you should exclude a patient in your treatment protocol. Some of the things to look for: prominent truncal movements, head movements in the horizontal plane, like a patient is shaking their head no, crying, forced eye closure, variable rate and direction of movements. So I usually ask parents, does it look more like a fish flopping movement rather than a very rhythmic movement that doesn't stop? Also, we need to know their history. Do they have a history of non-epileptic events? So many times we get patients come through the emergency room that have already had treatment either at home or by emergency medical services. It's really important to know which medicines have been given because we do risk respiratory compromise with multiple doses of benzodiazepines, but also with seizures themselves. So if seizure onset was out of the hospital, I generally assume the duration is at least 5 minutes and initiate the treatment protocol. And again, does the patient, if the patient we know has epilepsy, is there an individualized emergency plan? If benzodiazepines have been administered by at home or by EMS, then I like to proceed directly to the second line medications. And then IV access, obviously that is one important step in treatment, but we do have some other options, including intranasal and intramuscular injections for medications. So again, general measures, the first step is ABCs, IV access. Within 5 minutes, we want to get the patient a dose of a benzodiazepine. And I won't read through all this text, but you can see the doses there, including the dose of intranasal midazolam. So after 5 minutes, we give the first dose of benzodiazepine, the seizure continues. We give a second dose, and then we get the second line medication or an infusion of a loading dose of one of the medications ready to go. So with IV access, if you're going to get labs or, you have to do that at that time. And then again, second line medication after the second dose of benzodiazepine, 5 more minutes. Then we're talking loading doses of either phosphatidylcholine or levetiracetam. If the patient is already at the hospital, we're here to help. Please call us. And if the patient needed a loading dose, does the patient need to go to the ICU for monitoring? So those folks like to be involved as well. Also thinking steps ahead if the seizure continues, what are you going to do? So third, fourth line medications. And the definition as far as refractory convulsive status epilepticus, after you've gone through steps 1 and 2, as far as the first and second line treatments, then you're in the territory of refractory convulsive status epilepticus. So the practice regarding this differs institution to institution, but some of the more standard options that you'll see is initiation of a midazolam infusion, starting with a bolus dose, and then continuous EEG monitoring when we have patients on infusion is kind of our standard practice. Pentobarbital we will use as well, also continuous EEG monitoring. As far as monitoring on EEG, we want to titrate the dose of either of those medications to cessation of the seizures and sometimes even burst suppression. So 24 to 48 hours of control of seizures is recommended prior to withdrawal of those continuous infusions by the Neurocritical Care Society. So one of the things regarding the objectives is prompt treatment of status epilepticus is very important. So there was a study in 2018 that showed that untimely administration of first-line medications was associated with higher mortality, use of those continuous infusions, midazolam or pentobarbital, longer convulsion duration, and also more frequent hypotension. So I think the takeaway here is that the poor outcome could maybe be avoided by early treatment. Nonconvulsive status epilepticus, I think, strikes fear in everybody's heart, especially in the hospital. And as I said, we don't know really how common it is in children. However, in critically ill children who are in the ICU, there is a very high incidence of electrographic or nonconvulsive seizures. So 29 to 46% in the studies that are out there. One of the things about this is we typically can identify, or at least in the published studies, about 80 to 100% of non-convulsive seizures or electrographic seizures we detect on EEG within 24 hours or less. Indications for continuous EEG monitoring for status epilepticus, recent seizure or convulsive status epilepticus and persistent impairment of consciousness, refractory convulsive status epilepticus. So we've gone through the first and second line medications. If the patient is encephalopathic and has had some CNS injury, including stroke, traumatic brain injury, hypoxic ischemic injury, epileptiform activity or periodic discharges on a routine EEG. And then also we often use continuous EEG monitoring in patients who are pharmacologically paralyzed in the ICU for other reasons. One thing to consider before initiating continuous EEG is, do we need neuroimaging or do you think you're going to need neuroimaging? There are MRI compatible EEG leads, and we do have those available. So one of the things that you want to think ahead about. Shifting gears, neonatal seizures are kind of a different category. So seizures in the neonatal period are usually symptomatic, related to hypoxic ischemic injury, intracranial hemorrhage, stroke, CNS infection, and seizures are often focal and not generalized. So as far as a generalized tonic-clonic seizure in a neonate, it just doesn't really happen very often because of incomplete myelination. Neonatal seizures are hard to spot because they're often very subtle. Sometimes there are clinical signs of seizures, but 80 to 90% of seizures in one study were electrographic only. And as far as the definition of an electrographic seizure in a neonate, it has to be a repetitive evolving pattern. It has to be a certain amplitude on the EEG, and the duration has to be at least 10 seconds. So some of the circumstances where clinical events might lead you to think that a neonate's having seizures, clonic or tonic movements, and those are usually focal, forced eye deviation, myoclonic jerks, tonic posturing or stiffening. Usually we get a lot of continuous EEG requests for oral motor movements, bicycling movements, and then also a lot of requests for continuous EEG for apnea, bradycardia that is not otherwise explained in the NICU. So as far as the data on treating neonatal seizures and status epilepticus, it is not well delineated. Usually the standard is phenobarbital, the first go-to medication. One of the things about phenobarbital is that we know that long-term use of phenobarbital is not great for development. And in animal models, it has shown neuronal apoptosis. So although we use it, short-term use is probably best. More and more we're using levetiracetam. It does have limited neurotoxicity as compared to phenobarbital in animal models. However, the efficacy data is not as good as phenobarbital or phenytoin or fosphenytoin. So topiramate is an interesting one. And at one time there was an IV formulation. However, that is off the market now. So topiramate is interesting because there are some studies that suggest it has a neuroprotective effect. So I think that deserves some further attention. Midazolam, we definitely can use midazolam continuous infusions in the NICU if needed. However, midazolam also in animal studies has shown neuronal apoptosis. I usually use midazolam if a patient is already on midazolam for another reason, like they are intubated and they need sedation, they're already on midazolam for sedation, then I'll try to minimize polypharmacy. So status epilepticus in the neonatal period is quite serious. There's an increased risk of cognitive deficits, increased risk of neurologic sequelae, so abnormal exam findings. And the higher the seizure burden, the higher the risk of mortality. Some of the poor prognostic factors and higher mortality risk in patients with brain malformations, high seizure burden, and also premature patients. There was a new study that came out this year regarding outcome in neonatal seizures. And as far as seizures beyond the neonatal period, in this particular study, about 13% of these patients developed postnatal epilepsy. Unfortunately, of these patients with epilepsy, about 35% of them develop infantile spasms and 32% of those with drug-resistant epilepsy. Abnormal neurodevelopment was the norm for most of those patients who developed postnatal epilepsy. And then some of the risk factors they identified for postnatal epilepsy were severely abnormal EEG background and also greater than 3 days of seizures on neonatal EEG. So I think we have some challenges ahead of us with treatment of status epilepticus and neonatal seizures. As I mentioned earlier, there's wide variation in practice, institution to institution, and even within an institution. So inadequate dosing of benzodiazepines or second line AEDs is fairly common. And one of the primary reasons for seizures not responding to first line therapy is inadequate dosing of benzodiazepines. And we see that fairly often. The timing of starting the first line treatment, as I said earlier, the longer a seizure has been going on, the harder it is to stop. So if the first line treatment is not given until 15, 20 minutes after the seizure, it may not be as effective. As far as the number of administrations of benzodiazepines, generally with our protocol, we do 2 and then we're moving on to a loading dose of fosphenytoin, levetiracetam, something that nature. But we see, I think, a lot extra benzodiazepines and potentially respiratory compromise sometimes. And some of that is because we don't know what they got on their way there. So very important to verify. Sometimes it's difficult to identify children with status epilepticus. So that's another challenge, especially when they're out of the hospital.
Dr. Morgan, sorry to chime in. We are a little past time, so we can take a couple more minutes, but just to let you know if we could.
Well, let me skip ahead. One of the things I will say, if you have a patient who's coming into the hospital, who has epilepsy and is on an anti-epileptic medication, I will stress that obtaining levels is very helpful. And I do try to stress that over and over. That after we administer in the hospital, obviously the level is not going to be undetectable or low. So I'll just skip ahead and just emphasize that the Epilepsy Foundation has a lot of great resources, and please direct your patients to the Epilepsy Foundation website. It's really a good resource. We have a lot of work ahead of us, but I think there's some great things on the horizon, and we will work with you toward getting there, getting to prompt treatment and taking great care of your patients. So, any questions?